Hi, my name is Dr. Nicholas Connors. I'm a board-certified orthopedic surgeon, and I specialize in hip and knee replacement surgery. I work at Advanced Orthopedic Center, and we have two offices, one in Port Charlotte and one in Punta Gorda. A little bit about myself. Starting in 1982, I did 4 years of pre-medical education at DePaul University, followed by 4 more years of medical school at Indiana University, and then I went down to University of Miami, did a 5-year orthopedic surgery residency, followed by a 1-year hip and knee replacement fellowship at the University of Florida. I've been in town here in Port Charlotte and Punta Gorda for over 23 years and done thousands of hip and knee replacements. Today I'm going to talk to you about the Makoplasty robotic arm assisted total hip replacements. So first, what is the hip joint? The hip joint is that part of the pelvis that involves the top part of the femur, which is the femoral head, and the round socket part of the pelvis, which is called the acetabulum. When the cartilage wears away in this joint, that's what we mean by arthritis of the hip. By far and away, the most common form of arthritis that we treat for hip replacements is called osteoarthritis. That's the wear and tear arthritis, or arthritis of getting older. There's also traumatic arthritis from people who've had a trauma to their hip joint. There's rheumatoid arthritis, where the lining of the hip eats away the cartilage in the hip joint. There's also a condition that's called avascular necrosis, where the femoral head has lost its healthy supply of blood and the femoral head collapses. And then some people are just born with a bad hip, and that's called hip dysplasia. The diagnosing of arthritis is quite easy. We do it with physical exam, x-rays. If I'm concerned about rheumatoid arthritis or lupus, I'll get a blood test. So typically, people who have hip arthritis have groin pain. It's pain in the groin. If the pain is in the pain in the groin is there when they walk or stand, it goes away with sitting down or lying down. If people have pain in their buttock area, low back, or pain goes down their leg, or pain that's present when they lie down, that's typically pain that's coming from their lumbar spine. If the pain is localized at the side of the hip, that's usually a hip bursitis, and we can treat that with just a simple injection. These are x-rays of a normal hip and an arthritic hip. As we can see with a normal hip, there's a good space between the ball and the socket. That's your cartilage. When that cartilage wears away and the two bones touch, that's a person with advanced arthritis of their hip. And we have to remember that the nerve endings are in the bone, and so when the two bones rub against each other, that causes a lot of pain in the hip joint. Non-surgical treatments for hip arthritis include resting the hip, exercising such as swimming, bicycling, short distance walking. If that doesn't work, we can use over-the-counter medications such as Advil, Aleve. Sometimes we'll use some prescription ones such as Celebrex and Meloxicam. Also, one of the most important things you can do with hip arthritis is to lose some weight. You have to remember, every time you take a step, 3 to 5 times your body weight goes through your hip joint. So just losing 10 pounds can translate into 30 to 50 pounds less force going through your hip joint. However, for those people who have disabling pain in their hip joint and they have bone-to-bone changes in x-ray, unfortunately, exercise and anti-inflammatory medications aren't going to help. These people are going to need some sort of hip surgery. The gold standard right now for treating hip arthritis is a total hip replacement. We first started these back in 1960. A guy named Sir John Charnley did the first surgery back in the early 60s. It was a very big operation. They used like a 15-inch incision, took muscle off the bone, and the recovery took several months. Today, we perform over 300,000 hip replacements every year in the country, and we've gotten really good at doing these. I started doing these minimally invasively about 15 years ago. This is where we use a smaller incision. We don't take any muscle off the bone, and we cut through very little muscle, and it really helps improve the outcome and recovery. Most people with minimally invasive hip surgeries have a shorter hospital stay, a faster recovery, less blood loss, and a smaller scar. This is a cross section of the hip joint, and it's showing right here is the front part of the hip, right here is the back part of the hip, this is the ball, and that's the socket. People are always talking about whether you should do it from the front or through the back. As you can see, if we go through the front, we still have to go through muscle to get to the hip joint. If you go through the back, you also have to go through a little bit of muscle. Either way, you're not taking any muscle off the bone. The studies show that there's no difference in how patients recover, so both ways work well. I like the posterior approach because I think it's a more direct way to getting to the hip joint. I think it's a little bit more minimally invasive, definitely less blood loss, and some of the studies show that there's less complications doing the posterior approach compared to the anterior approach. What's most important is that you go to a surgeon who does a lot of these. Medicare several years ago looked at why there were complications with hip replacements. They looked at, in this country, 52% of all hip replacements done are done by surgeons who do less than 10 a year. So that's less than 1 a month. The study also reviewed that if the hip surgeon volume was over 50 replacements a year, that would be about 4 a month, 1 a week, the complication rate decreased by 67%. I do well over 100 of these, so my complication rates are almost non-existent. So what exactly is a hip replacement? If the patient has an arthritic hip, we take off the arthritic ball, we put in a titanium cup in the socket part, snap in a piece of plastic. Then the femoral side, we thread in or pound in a piece of titanium metal that which matches the shape of the patient's femur, and attach a ball to that neck. Now the patient doesn't have bone touching bone, has ceramic touching plastic, and the pain goes away. What you need to notice is that this hip has to be put in the right position. This cup has to be put in at about 45 degree angle, facing a little bit forward. If it's put in too vertical, or if it's put in too horizontal, this would be too vertical straight up and down, or too horizontal crosswise like this, the hip will impinge and dislocate and wear out prematurely. So it's really important to put it in the right position. There was a study that came out in 2010 that won an award by some surgeons up at the Harvard Medical Center, and they realized that when they put in their hips, only 50% of the time did they have them in the desired position when you talk about putting in the acetabular component, or the part in the pelvis. So even the best of hands, the hip joints only put in correctly 50% of the time. That's why some smart people came up with putting them in robotically assisted. It's a more precise way of putting in a hip replacement. It's almost like getting a custom hip replacement. So the basic premise is we get a CT scan of your hip, and we pre-plan out the case so we can determine exactly what size and what's the best position based on the patient's unique anatomy. Then we use a robotic arm to assist us in placing the components of the hip in the perfect position. And then we're all done. We can double check and make sure that it's been put in right. So here's what it looks like on the pelvis side. The green represents the cup that we put into your pelvis, and this slide right here shows the inclination. And we want to put it in somewhere between 35 and 45 degrees inclination. Here we chose 40 degrees. This side also shows the version that we want to put it in. Anywhere between 15 and 25 degrees of version is good. It's basically based on the patient's unique anatomy. And it also tells us how deep we're going to place the cup and how much bone we're going to take away. When we look at the femoral side, the blue represents the stem that we're going to put in your femur. And again, it has to be the right size. And based off the CT scan, we can determine exactly what's the right size stem based on the patient's unique anatomy. It also tells us where we need to make our neck cut so the leg's not too long or too short. When we're all done with the procedure and the robotics helped us place the components in, we can double check how we're doing. For inclination, we wanted 40 degrees. We ended up with 41 degrees. And for leg length, we need to make the leg 3 millimeters longer to match the other side. We actually made it only 2 millimeters longer, which is very close. When you do it non-robotically, the manual way, leg lengths are usually off anywhere between 5 and 10 millimeters. So the advantage of doing it the Makoplasty robotic technique for hip replacements is that by putting in the implants more precisely, you'll have less complications, less likely to dislocate, less likely to have bony impingement, which will make the hip wear out prematurely, and it also reduces the chance of having a leg length discrepancy. It's the most accurate way we can do a hip replacement. Remember, 50% of the time, even the best of hands, these hips are only put in the correct position. Thank you.